Welcome, and thank you all for joining us today for the Healthcare Supply Chain's response to COVID-19 provider panel discussion hosted by the AHRMM Learning Community. Hi everyone, this is Mike Schiller, Senior Director of Supply Chain at AHRMM, and I will be moderating today's session. Just a quick note for those who may be unfamiliar, AHRMM is a national professional association dedicated to providing education, leadership, and advocacy for the healthcare supply chain professionals. Throughout the COVID-19 pandemic, AHRMM is working closely with government agencies, healthcare leaders, and professional organizations, GPOs, manufacturers, and distributors to provide the most up-to-date information and resources. A few housekeeping items for today's call. All lines have been placed in a listen-only mode, but you can ask questions by typing them in the Q&A box. The Q&A box can be opened by hovering your mouse at the bottom of the WebEx browser, clicking the ellipses icon, the one with the 3 dots, and clicking Q&A. The Q&A will be held towards the end of today's session. As a reminder, AHRMM will be developing a takeaway document after this session and will de-identify and include feedback you share with the healthcare community. We are excited to welcome our expert panel of leading healthcare executives to today's call. Today's panelists are Alan Edwards, Vice President of Supply Chain Solutions Group at Mary Washington Healthcare, Laura Kowalczyk, Vice President of Supply Chain and Support Services at UAB Medicine, and Bob Taylor, Senior Vice President of Supply Chain at RWJ Barnabas Health. Thank you all for joining us today. So we're going to start today's session with a quick polling question regarding tracking of costs. How are you tracking COVID-19 expenses? Are you utilizing your current expense account categories, creating special expense account categories, or other? Audience, feel free to share any additional details around what your facility is doing in the chat box as well. And while we wait for the polling results to compile, I'd like to ask our panelists to briefly share their approach. Panelists?
So this is,
I'm happy to start.
Go ahead, Laura.
Yeah, so we are tracking all of our expenses under a separate GL and expense account here. We call it uniquely, of course, the COVID-19 account. And that way we are tracking every single, whether it's a supply, a capital item, a service, anything that is attendant to addressing this response to the pandemic.
This is Bob Taylor. We're doing the same thing. We also add additional labor and contract labor costs into that so we can isolate it.
Hi, Alan Edwards would chime in. We're doing the same thing. We had the forethought early to establish a COVID cost center. As Laura said, we have now added an activity code so that in our ERP system, we can bring those supplies directly into our warehouse, as tracking them and issuing them out to the departments has been the biggest challenge for us.
Thank you, panelists. The polling results are up. It looks like we've got a fair amount of folks, the majority really, that have no answer. I'm not sure if that's because there wasn't enough time given to respond to the poll. Other responses, 8 are utilizing existing supply expense categories, and 30 have created a special expense category. We had 18 who responded with not applicable. So let's move into our first question for the panelists. What strategies have you implemented to optimize, conserve, and/or reuse PPE, including any decontamination efforts? Alan, let's start with you.
Thanks, Mike. We've set up a series of processes, if you will, to step through. The first thing that we did early on was secure the supply chain. And while you may have a warehouse with physical barriers to keep that inventory secured, we went a step further and implemented some processes that implemented more strict internal controls. The organization is also pushing PPE conservation out across the organization. We have prioritized PPE issues, so we have a matrix. We have a COVID cohort unit where we are trying to keep those COVID patients in. So ICU, ED, a couple of our nursing units, they're getting the first come, first served, if you will, when it comes to PPE. And then we're doing a PPE inventory daily and sharing those counts with our senior leadership team because they're making clinical practice decisions based on the availability of PPE.
Great. Thank you, Alan. Laura, what efforts have you guys implemented at your organization?
Yeah, so very similar to Alan, we centralized all of the COVID PPE in the supply chain. There is nothing out on PAR locations, and the units can no longer order. We do all of the ordering, and we actually developed a matrix, and on a daily basis we have a matrix that is designed for each area, whether it's a procedural area or a unit level, where we issue out that PPE. We also report out days of inventory on hand on all of our critical PPE. That's done on a daily basis, and supply that across the organization so that folks are very well aware of where we are around those critical supplies. We have cohorted units as well. I do want to briefly touch on our reuse strategy we have implemented for the last 2 weeks. We have been using extended use in the N95 category. We are using 3 types of reprocessing. We are using a VPRO, sterilization, hydrogen peroxide, the BioQuell, which is also a hydrogen peroxide gas, as well as UV light, dependent upon the item that we are reprocessing.
And you guys are doing all that in-house, Laura?
We are doing all of that in-house, yes.
Excellent. That's great. Thank you so much. Bob, how about you?
So we're doing everything that was already mentioned. Just so everybody's aware and probably know, we're up in New Jersey, so we're kind of on the front end of the wave. We are controlling distribution. We use third-party warehouse for distribution. We have locked down who can order those supplies, and we have moved a lot of product into customer-owned inventory where we pre-buy it, so it's completely invisible to anybody else, and then we enter the orders. We're doing supply allocations based on what percent of the overall number of COVID-positive patients you have in your facility. We do have 11 facilities. So we're actually constraining supply to some degree based on where we have recognized that the demand should be. And that in turn forces a little bit of a conservation strategy. We have mask and PPE policies out across the system that are now 1 mask per shift, 1 gown per shift, unless we have visible soiling or gets contaminated. We're looking at doing reprocessing and reuse on blue light using STERRADs in our, we have 14 STERRAD units for plasma. We're having a conversation about the Bastel system, which is capable of doing a very large number of masks in a single pass. Each facility has a command center. All PPE supplies have been secured, and they're basically being given out and allotted on a very tightly controlled basis to make sure that we can conserve and extend as much as possible. We have a couple items that are so critical that I'm very concerned that we're just going to run out probably within about 2 weeks.
Thank you, Bob, for that. And just for the audience, Bob had mentioned a program, the Patel program. Excuse me. They have 3 active facilities right now where they use hydrogen peroxide gas and can sterilize up to 80,000, I'm sorry, not sterilize, I need to correct myself, decontaminate 80,000 masks a day. The current facilities are in Stony Brook, New York. They're in Ohio, which is also servicing Michigan and Indiana, and in Tacoma, Washington. They'll be setting up a second facility in New York, another facility in Boston, and a facility in Chicago, I believe. They expect to have those up next week. So there's more information on the AHRMM Daily Update that went out yesterday and on the AHRMM website, but a lot of promise there, at least to get some masks back into the healthcare supply chain. So let's move into our second question. Have you utilized non-traditional vendors? And when I say a non-traditional vendor, I mean vendors who typically have not sold in the healthcare space or other supply channels to procure supplies? And if yes, what processes have you used to identify or to vet these vendors? Laura, let's start with you.
Yeah, so the quick answer to that is absolutely. We have had to look at alternative channels for sourcing. We, probably like many of you, we have been inundated with offers around donations. The community has been tremendous, but we found that there's very little of that supply that is either of a substantial amount that can help, service the size of the facility, or perhaps they're not hospital grade. So we have also put out a call. We have researchers here. We have local contractors. We have a student population. We have the vet schools, the medical offices. All of those have been early options for opportunities around PPE. But most importantly, we all have been in a barrage of these alternate sourcing, more broker-type relationships, I think, where someone has the option of having perhaps a connection either locally or personally with some entity in China or Mexico or a foreign country. Even internally, regionally, we've had some of these offers. And so the way that we've had to manage that is actually to set up an alternative sourcing group. We have a team of individuals who respond to these offers. We've set up a database so that we know what offers are viable. We have a sourcing group that pre-sources for my sourcing team, and then it gives us the opportunity to actually go forward with sources that we find to be more legitimate than some of the others. Outside of that, we also have worked very, very closely with our clinicians in infection prevention, and we have a whole arm that we call our innovation arm, and that is those innovations that have come to us, whether they've been clinicians, they've been local engineers, they've come from the School of Medicine, or they've come from many universities here, not only on the academic medical side, and we literally have a team that is vetting different innovations around different levels of PPE, the most critical of which, as we know, is around the N95 mask.
Thank you, Laura. Being an academic center, are you guys engaging in any 3D printing?
So we have more 3D printing than we know what to do. I would say probably hundreds of offers around 3D printing. We are bringing all of that internal with our own engineers just from a quality perspective. And yesterday we looked at 3D options for valves to place onto scuba units that I know many of you have probably already seen out there. Stanford has really brought this to the forefront, but we did procure quite a number of scuba masks, and they have all been retrofitted through our own internal 3D printers and filtering material that we have determined is of a N95 grade. So those are actually in operation in our anesthesia department.
So it sounds like you guys are doing some 3D printing on site as well as looking out across the field.
We have we have the opportunity of very robust 3D printing on campus, yes.
Excellent, excellent. Thanks, Laura. Bob, how about you?
So like Laura, we are doing an immense amount of alternate sourcing strategies. We do try to pull everything we can through the normal traditional supply chain, but I think many of the suppliers are in a similar position where the supply chain is just drained, which is forcing us into alternate channels. I feel like a drug dealer half the time because we're doing escrows and putting money up and negotiating deals. About 5% of them are successful. 95% of them collapse because our requirement to at least have some independently verifiable proof that the product exists never comes to fruition, and we can't come to terms. So it's a pretty interesting world. And like Laura, we get a barrage. We probably get 300 to 400 emails a day from people that are offering us things. And interestingly enough, there's a spreadsheet now circulating that I think some broker has just signed up a bunch of people to go out and solicit, almost like a cut code knife program, where I'm getting the same spreadsheet sent to me from 50 different people with the exact same pictures and catalog numbers on them. So it's a very unusual market.
Yeah, it's a bit of the wild west out there, Bob. I know we're getting hundreds of emails a day as well here at AHRMM and through the AHA. Alan, what are you guys doing at your organization?
I would echo, Mike, exactly what Laura and Bob said, in that we are completely overwhelmed with legitimate offers to help, with tentative offers to help. We started out early with broker deals, people who knew someone, a connection of a connection, and wanted to use their import relationships. Those quickly escalated to we couldn't afford the buy-in from a minimum order quantity or the minimum dollar value of those orders. And so we're looking at alternative sources. I think much like Laura talked about, to me, that innovation, we have an innovation group that kicked off this week, and we are partnering, for example, with a Navy base that's in the area. They have about 5,000 employees. 80% of them are scientists and engineers. They want to help. And so we're working on fast-tracking a working partnership agreement with them. But they can do production. They're not healthcare experts and made that very clear, but they're willing to help us, for example, with things like how do we keep N95s on our clinicians when the straps keep breaking. I think non-traditionally we have reached out to people that we typically wouldn't reach out to, but we're doing the same thing. We're vetting every vendor. That is a hard thing to do in the heat of the battle. As I said, we're finding lots of counterfeit items or deals that you get blown out of because of somebody else made a better offer. One of the things I would offer to the group on the phone, on the webinar, is that if you aren't familiar, there's a website called Goggles for Docs. It's Goggles, F-O-R, Docs, and they actually started off kind of a grassroots effort to get ski mask, goggles, anything like that, new and used in solicitations. Easy registration. They reached out immediately and said, okay, we've got you on the list, and we will see what we can do. So you have to give them a quantity, but we're taking those sources seriously and trying to vet them to the best we can. The last thing we want to do is put faulty product in the hands of our clinicians and put them at risk. So probably the best success story we've had to date is someone who was a shoe importer, had relationships in China, had a relationship with someone in my network here in Virginia. And so we kind of connected each other, and in turn was connected to this importer. And we actually, again, like Bob said, it's, how much do you want up front? It went from I don't want anything up front. I've taken business loans to front the mask. I just want to help the communities here in Virginia to, hey, I need 50%. And so we're like, okay, what's the risk? So it really is all about the risk to the organization. Working for the CFO, I can tell you that he's watching cash flow every day, watching expenses. We put some limits in place, if you will, into what supply chain can do without bouncing it forward to our senior executives for discussion before we buy capital and or supplies.
Thanks, Edward, for that. I appreciate it. Have any of you looked or reached out or working with FEMA in their Air Bridge program? Are you getting supplies through FEMA or your state and local emergency management agencies?
So this is Bob. We have gotten things from the stockpile from the state. Unfortunately, a lot of the items were horribly outdated. We have started to get ventilators in from the stockpile. Those are being allocated based out on demand. Of course, us being immediately adjacent to New York, although we have a lot of need, it kind of is overshadowed by what's happening in the city right now. I'm not sure a lot of those channels are probably a politically incorrect thing to say. They're not very helpful. They're diverting our sourced inventory that we had anticipated receiving from the manufacturers is now being commandeered by FEMA and taken into a FEMA route, which just adds more complexity and difficulty for us to be able to access it and delays it. So far, I have not seen that to be a terribly effective solution.
This is Laura. I'm going to jump in and agree with Bob. We have received some initial material from the state and from the SNS, federal SNS, and have found most of it really not extremely helpful, some of which we are even using just for what we're calling our universal masking strategy here, where we are providing covering for all of our healthcare providers on a universal basis, but they are not, these are not masks that we could use for the protection in a procedural area. The other thing that we have found is, although the state wants to provide assistance through their procurement teams, their level of expertise around healthcare and healthcare needs has not been tremendously helpful, and we end up being the resource for the state, which is additionally taxing on our team, and is one of the reasons we brought in a number of other individuals who may be working in alternate jobs or off-site who have the ability to come in and help us do some of this sourcing, because we do find ourselves to be, we're the largest entity in the state, so we have become sort of a resource for the state in that regard. So I'm with Bob. It's more productive for us right now to, unfortunately, do what we can on our own.
Thanks, Laura. Alan, anything to add?
No, I think we are tapping the same resources. We've had a couple of national stockpile deliveries. To Bob's point, you have to sort through it, figure out what's good, what's fallback stock, as we call it, last line of defense. We have a couple of shipments that have been received from the state. Again, it isn't enough to sustain us for the long haul. And then we also belong to a group in Northern Virginia that has done a great job of keeping track of resources across the region, and they also had a stockpile, if you will, so we've received those. But I think that having to sort through and figure out, what we're doing and making sure that we're one of the things that we were asked, for example, was every time we use a different kind of mask, can you give us a picture of it? And so imagine that going out across, multiple hospitals with thousands of employees and those frontline staff who, are kind of questioning each other and peer checking and saying, that's not the same N95 that I saw you wear yesterday. Are you sure it's a good N95? So I think to Bob's point, sometimes it isn't as helpful as maybe everyone thinks it is.
And I think just kind of commenting on one of the things you just mentioned about the different N95s, fit testing has become horribly burdensome because we're sourcing N95s, now KN95s, just to be able to have them available, but the fit testing requirement to try to switch in between all those masks is kind of overwhelming.
Well, thank you all for that. Let's jump into our next polling question. I want to invite the audience to answer the second polling question. Are you creating new item numbers for the substitute products that you potentially are bringing in, masks, swabs, etc., or are you using the same item number within your ERP? And again, while we wait for the poll numbers to compile, I'd like to ask our panelists to share what they are doing. Also, for the audience, if you want to share some additional details about what your facility is doing related to this polling question, please enter that information into the chat box. But panelists, what's your approach on this?
Well, this is Alan. We candidly were in the middle of a new ERP transition. We were in the build phase, and so we were trying to hold changes in the system to a manageable point. And I think that when this escalated, Mike, it escalated so quickly that we didn't have time to go through and at the time think about how we could best utilize the ERP system that we have in place currently. So we ended up with a series of spreadsheets for locations. Those spreadsheets are updated. And of course, then the next thing that happens is senior leadership asks you for a burn rate, which is the new buzzword for me in supply chain. And we're trying to make sure that, as Laura said earlier, they want to know how many days stock on we have on hand. And that is a legitimate question in the current environment. But in answer to your direct question, we recently met and decided that we could start moving some things over to our ERP. We will be creating a new item number for things that aren't normal products. So if we have an N95 that's a standard in the ERP system, but we're getting something that's a little different and isn't a true sub, we are creating an item number for that. And then our sourcing director would recommended that we create that with a character, at the end, so an alpha character, so that we would be able to know that is a donation item or a like item, so we can roll those numbers up for the count.
Thanks, Alan. Bob or Laura, real quick, do you have anything to add?
So,
the only thing I'll add, we're doing something very similar. We're not changing the process tremendously. If it's a similar product, we're using the Lawson number. If it's uniquely different, we are creating a unique item number. But what we've done is restricted all of the PPE under the same purchasing class, so it gives us the opportunity to be able to pull that information very easily. All of the affected PPE has been moved to an inventory location, and we issue that PPE out of that particular inventory location to the departments based on the matrix that I referred to earlier that we've worked through with our clinicians in the supply chain. And then we physically either house the inventory or we place it into a virtual inventory. And with the bin location is, quite frankly, our warehouse. And that way we are able to do that report out much more easily under the daily days of inventory on hand. We can put our fingers on it very quickly to report out on a daily basis.
In RWJ, we do a little bit of a mix. So we have been very much in a scramble on a lot of supplies. So one thing we have done is if we're able to source something in a very small quantity, we're basically, it's going to be come in and go out, and we're never going to see that item again from that vendor. We actually have a parallel distribution, pathway that we have set up, and we use that for both donations and then for some of these smaller orders where we simply order it using, call it non-file or item by description, whatever your choice word is. We ship it into that location, we disperse it onto pallets, and then we aggregate donation and some of these other things on pallets and push that out to the hospitals as quickly as we can. Downside of that is we don't have the clarity or the visibility that we might like to have as far as what has come in and what has gone out. But we're doing that when there's just small quantity. Large quantity gets an item number set up. It's going into a customer-owned inventory in our distributor's warehouse, and we're able to track, view, and monitor that.
Thank you all. I really appreciate those insights. So the polling responses, we've got 28 who are creating new items. We've got 22 who are not, and 26 saying it's not applicable. The balance did not answer the polling question. So with that, I'd like to open up the floor to some questions from the audience. As a reminder, to ask a question, please type it in the Q&A box, which can be opened by hovering your mouse at the bottom of the WebEx browser. And let me ask a couple of questions that have come in so far. How are you dealing with staff who is concerned that strategies to conserve PPE by limiting masks and gowns is not sufficiently protecting them? I know one of you had mentioned, I believe had mentioned that, but how are you dealing with that concern? How are you addressing that?
So this is Bob. I mean, we have a couple phone calls a day, every day, with executives and leaders across the organization, there's not an easy answer because we are constraining because we are constrained to make sure. We have not had an instance yet where we actually have been out of anything. It's probably not popular to have a mask per shift and recognize that's probably not a preferred practice, but there's a lot of things right now that are not probably preferred or normal. Just trying to make sure we can have adequate respiratory, facial, eye, and body protection is become probably more the norm rather than trying to have what we would normally consider to be copious amounts of available PPE.
Yeah, I'd like to jump in on this one too. We've stayed very close to our clinicians and infection prevention teams, and we are also very much into transparency and open communication about where we are on these items. So, like Bob, it's not optimum, but we have a plan for isolation gowns. That's our critical need right now. We've only got 11 days of inventory on hand, which to some of you on the phone may sound like a lot, but the burn rate is tremendous. So we have a plan that we have shared, and it is based on what is available. And we have worked with our clinical units on how we tier those particular items to which units. Our COVID cohorted 7 units will get a certain category of product that will serve as an isolation gown, and some of the other units will perhaps have a different category of item. But it all comes to being very, very close to them and explaining what the options are and why those are our options right now.
And Mike, this is Alan. I would add to those comments by saying that we have taken kind of a playbook matrix approach, if you will, and we're looking at those PP items, just like Laura just said, and that, for example, I'm going to use Sani wipes as the example. We've included that in a critical item status. And due to the fluctuation in on-hand inventory and availability, and so if you will, if the cohort units or the ICU or the ED are your priority A's, we know that they're always going to get Sani wipes. So then we're taking it to the next level and saying, and here's the next priority if we could supply Sani wipes to them, and then we have this C priority list that would suggest that could they use Clorox wipes, for example, that are being donated by the community. So we have a multidisciplinary group that looks at that. They're looking at, what's the harm to the equipment if you start using it other than the manufacturer's recommended product. We've actually had a distillery that donated to me a sanitizing solution, and we want to be careful using that because we don't want to do long-term damage to the equipment that we have. Just lots of different things, I think, that we're all thinking about how we can serve all of those critical items in the PPE bucket, if you will.
Yeah, wonderful. Thank you guys so much. Are any of you involved in setting up a field hospital? And if you are, do you have any experience or tips that you can share with our audience?
So this is Bob. We are not setting up field hospitals, however the government is. And what we're experiencing is while they may have tents and cots, they don't have people. So they're basically just coming in and cannibalizing the existing infrastructure. They're also not taking COVID patients or have not been taking COVID patients. They're taking very limited, low acuity patients, which is, I think the last count I heard there were 20 patients in the hospital, in their field hospitals. So they have not yet demonstrated that they're relieving our hospitals of the demand that we're experiencing.
Thank you, Bob.
Here at Mary Washington Hospital in Fredericksburg, Virginia, we have outfitted a field hospital of sorts, and we actually converted a lower level of a parking garage, and it's framed in. It has power. We have everything we need to see patients, and it was really built more as a surge facility. The initiative was led by one of our ED doctors, It's out on YouTube. You can go Google it and kind of see what they did, but it's a way for us to be able to take this onslaught of patients that candidly we're expecting in the next week or two.
And we've done something similar at UAB as well, as more for surge here, utilizing other opportunities in the community, whether it's a convention center or a hotel type of arrangement. And what we have done is just, we are, looking at the modeling for the surge and then making staged plans and trigger points based on when we would potentially need to use those types of facilities. Right now, our efforts are really around partnering with the other hospitals in the city to see how we can share in the surge for the community as a whole and keep our patients in the beds that we have in our facilities.
Thank you, guys. Another question here. We've got quite a number of questions, so I'm going to go ahead and just select a couple here. How is your organization, or how are you protecting supplies and managing supplies to non-clinical staff, EVS, dietary, etc.?
Well, this is Alan. In our facilities, we have taken the approach that the clinical facility, the hospitals, if you will, they are where we are issuing PPE to first, and then within that, at first it was everybody kind of went in hoarding mode, and so if someone from EVS were to go up to one of the nursing units, they might be told you need to bring your PPE equipment with you. And what we said now is, in order to understand the burn rate at the individual department level, we need those people to go get their PPE, if it's their first PPE of the day, from the unit that they're working on. In the ED, we have EVS techs that are assigned to the ED, so it's the same staff coming back. But in the heat of the battle, their EVS and the food and nutrition services folks, they're all plugging and playing as demands shift, and they try to meet those needs. So for us, it's go to the unit of origin, if you will, and we'll capture that there. We do have some groups that we're doing one-offs with. Our hospitalists, they're managing their own N95 mask. The OR and anesthesia are intensivists. So we're carving out some things so that they can do their own thing, but they are expected to follow the same precedent that we have set for the organization. As Bob outlined earlier, it's one N95 mask per shift. Put it in the brown paper bag when you're not wearing it. And at the end of the shift, you go to the collection site on the unit and you drop it in for reprocessing.
We're doing something similar here. The only thing I would add to that is we are also very mindful of how our support teams are or are not entering the COVID cohorted units and specifically patient care rooms. So our food service individuals do not enter those patient care rooms, nor do our EVS staff, unless there is obvious soiling that has occurred. But they are protected to the same extent that our clinical teams are protected when they are or need to be on those units, or they are housed on those units for support.
Thank you, guys. All right, another question here. How is your organization addressing the mental health management of the organization itself? There is a lot of fear among all levels of staff within the hospital setting, and there's certainly an extreme amount of stress. Are you guys focused? Do you have any type of initiatives in place? How are you addressing this?
So I could probably speak to that because it's a problem here. We have 1,400 positives in our buildings right now. And the mortality rate here is just astonishing because we have a no visitor policy now, which many people do. Most patients that are dying alone, and the caregivers are having to make an incredible amount of phone calls to family members. So we're bringing in grief counselors. We're bringing in the employee support groups, the EACs, to try to provide a level. We've also had a number of employee employees have actually passed, which creates an additional burden on the organization mentally and emotionally. So it's probably has yet to be realized. I think this is going to be one of those situations where the grief is going to come later, but we are experiencing a lot of it now.
The only thing I'll add to that we're doing, and we do not have that level of high death rate that Bob describes. I personally can't imagine that for the organization, but what we are seeing is the sickest who cannot have visitors, so we have deployed telehealth tremendously, and we have just bringing in several hundred iPads and trying to support both from spiritual care, whether it is some type of grief support, and family members being able to communicate with their family members through the use of technology so that we avoid or minimize what Bob describes as individuals having to be ill and horribly dying without family.
We have done that as well. We've brought in a couple, probably 1,000 iPads, just to try to give family members a connection back into their patients. It doesn't eliminate the previous comment, though, unfortunately.
Thank you, guys. We've got just a few minutes left, so I'm going to ask the last question here. And it's got a bit of a focus towards, hey, we're going to come out of this, and what's the preparations look like? So let me read the question. There's 3 of them around this, and just if you guys can come up with kind of a response to address these 3. Do you feel that the supply challenges will shift the healthcare supply chain towards reusable healthcare textiles in the future to reduce the challenge with the disposable supplies? And what are you most concerned about with your operations getting back to normal once this is all over? What has to be put back, what has to be changed, etc.? And do you have any future outlook on where staff should be preparing next once the surge in the crisis response phase has come under control? Do you expect other bottlenecks if and when the new normal comes? So I know I tossed a lot at you there, but again, these 3 questions run along the same vein. So I'll turn it over to you, panelists.
I'll jump in first. I don't know if I'm right now optimistic that reusables are a solution that shifts demand from one stream to another. And I don't know right now, even if we were using reusable gowns, if the laundry could keep up and if there would be adequate supply, because we're burning through about 1.5 million isolation gowns a month right now. And to try to switch that from a disposable to a reusable channel would probably overwhelm the laundry infrastructure. As far as returning to normal and what's next, I think about that a lot because we have everybody working from home. So we very expeditiously emptied the entire centralized supply chain, got them home. It's a very different, challenging work environment because, different workplace, and some people don't have printers, and you can't print when you're VPN'd into the system. And there will be a point, I'm confident, probably won't be for another 60 days if I had to speculate, that we might be able to start bringing people back into the office and having that return to whatever we would call normal. What I'm most concerned about next is the anticipation that we're going to see round 2 of this. And if we see round 2 of this later this year, I'm not comfortable yet that the supply chain is going to be able to restore to any type of normal health in time for us to get ready for round 2. So, this virus is going around the world, and it may escalate and highlight in different parts of the world, and because of that, the demand on the production and the manufacturing is just going to be incredible for quite some time. And to get back to what we would think is a normal, healthy supply chain is probably going to be exceptionally difficult while that's going on. And if there's a reemergence or a resurge of this in the fall, I see that we could be very close to where we are right now trying to deal with this. Sorry.
This is Alan.
Thank you, Bob.
I would agree with Bob on those points. I don't know that it'll ever return to normal. I think a new normal is going to be defined. I think for me, what's next concerns. My concerns are about my staff, the staff across the hospitals. They are psychologically, they're worn out right now, and they go at it hard every day trying to take care of our patients. And so for us, we've already pushed our go live for our ERP system back. I think we're going to have to push it again. And that's a reality for us because I'm not sure how much more we can take. And this panel, for example, candidly was a distraction for me, and a good distraction because sometimes you need to step back and breathe. So I appreciate AHRMM putting this together and having the opportunity to participate.
Thank you. That you said it's a good distraction.
Yeah, it is.
Laura, any closing thoughts from you on what's next?
No, I would echo that, and as we look at, this flattening out, and we're talking in Alabama, looking at a pretty slow, steady burn, just the same concerns for staff, but also the same concerns around, opening surgeries back up and opening some level of operations back up and opening our clinics, and how is the supply chain going to meet that additional demand in light of having to continue to support, as Bob points out, the continuation of this illness. So that kind of blows my mind right now. I don't know what that's going to look like, and I can't conceive of us being able to support it through the supply chain as constrained as it is.
Well, we've gone a couple minutes over, and I appreciate the audience for sticking around, and certainly appreciate our panelists for all of their information and expertise that they shared and hanging around for a couple of extra minutes. So please join me in thanking Alan, Laura, and Bob once again. We really appreciate you guys taking time out of your hectic schedules, as well as the audience. I know everybody's so constrained for time, which is why we wanted to keep this to 45 minutes. Again, as a note, we will be putting out a final deliverable report on this with the questions. The Q&A that we didn't get to, we are going to ask our panelists, time permitting, if they can go ahead and respond to some of the questions. So again, based on their availability, we'll get you back some responses on the questions that we didn't get a chance to ask. Thank you, everybody, for your time today. If you have any additional feedback or questions, please email AHRMM at AHRMM@AHA.org. That's AHRMM@AHA.org. Thank you all for joining us, and thank you for your continued hard work during these challenging times. Bye, everyone.
Bye, everybody.
Bye.
Stay well.
Stay well indeed.